carry on.
Okay.
We'll wrap up this stuff.
And so, I mean, you were all very, for those of you that really wanted to see, no, I'm just kidding. I was like, I'll at least show you, because that alarming trend, I'm sure you might see it more later today. But anyway, so that we'll hear from now our presenters. And so the floor is yours, Angela. Thank you very much. And thanks everyone for being here. Yours are loaded.
You. All right. Well, thank you. I'm Angela Martin. I'm a maternal fetal medicine physician at KU, and I've been the medical director of labor and delivery over there for almost 4 years now, 3 years, a little over 3 years. So I really appreciate the invitation and the opportunity to speak to you guys today about this very important topic. My objectives are to outline the scope, which we've already heard a little bit about, and then understand some of the root causes. And then I hope to provide you with about 5 evidence-based solutions today. So the scope of the problem. This is no surprise to anyone who's attending a conference like this, but over the past 60 years, the risk of maternal mortality among Black women has consistently remained about 3 times higher than that of other races and their white counterparts. So this graph is from the CDC. Does my arrow show up? Oh, it does not. Okay. So this graph is from the CDC. I highlighted the mortality rate per 100,000 live births for Black patients, and then below that in red is the white, non-Hispanic, and other races. What's equally as alarming is that in 2020, the CDC did a study looking at 38 different mortality review committees from 38 different states, and they found that over 80% of these deaths were likely preventable. So maternal mortality is the tip of the iceberg, as they say. So for every mortality, there's many, many cases of maternal morbidity. We know that non-white races have increased risks of cesarean section. We know they have increased rates of postpartum hemorrhage, blood transfusion, even hysterectomy after delivery is more common among non-white races. And because of all of this morbidity, it's no surprise to learn that their hospital stays are more costly and they're longer than their white counterparts. So we can't really begin to reduce these disparities without first understanding why they exist. I borrowed this really great flowchart from the California Maternal Quality Care Collaborative webinar on perinatal equity. Black women in the United States have a very distinct, traceable history of discrimination with very easily identifiable stressors related to anti-Blackness. And I want to take a minute to define anti-Blackness. There was a really great article published in the Green Journal, which is the Obstetrics and Gynecology Journal, last fall, and the title is Why Causation Matters. Rethinking race is a risk factor. And I really like the way authors define anti-Blackness. They defined it as the beliefs, actions, and practices by individuals and institutions that devalue people of or perceived to be of African descent. So anti-Blackness encompasses inequities in almost everything: education, criminal justice, science, politics, communities. And these inequities and toxic exposures over and over again have really dangerous effects on stress and can certainly affect biology. But in addition, there's also racism within healthcare institutions. And in that setting, it's termed obstetric racism. One really common example of obstetric racism that I'll share with you. So when I was in residency and fellowship training, Black race was often considered to be like an individual risk factor for certain adverse outcomes. So being Black increased your rate of preterm birth. Being Black increased the rate of C-section. But by blaming the race, the non-modifiable risk factor, we were completely absolving the institution and the obstetric racism and our own implicit bias that was actually contributing to those adverse outcomes. So let's move on to talk about ways that we can hopefully be a part of the solution. These are some of the resources that I used in this next part of my presentation, along with some of my own experiences. All right, so evidence-based solution number 1. By reducing implicit bias in the individual healthcare providers that are seeing these patients, hopefully we can buffer some of the obstetric racism that they encounter. I've listed a few ways here that departments and healthcare institutions can address implicit bias. So they can close their clinics or their practices for a half day and, provide an implicit bias training. I think it's really important that if that is done, it's multidisciplinary, because it's not just the obstetrician, it's the anesthesiologist and our pediatricians and other people that interact with the patients as well. I think it's important to invite everyone. So, people who sit at the front desk all the way to the chair of the department. And in my opinion, these are really well attended. So as healthcare providers, we hear about these statistics a lot, and it really does start to feel, hopeless and helpless. So these are really well attended, and I really feel like that healthcare providers are really ready for actions and plans. Something else you can do is create a slide when you're reviewing adverse, maternal morbidity events. Ask yourself, did the adverse outcome have anything to do with race, ethnicity, implicit bias, language barriers, or any other specific determinant, social determinants of health? And most institutions do have some sort of review process for adverse outcomes. This is the example of the slide that we include in our maternal morbidity and mortality conferences to hopefully help address that. All right, moving on to evidence-based solution number 2. So leveraging data and enhancing surveillance to improve outcomes helps you identify gaps that you can then focus your interventions towards. You can do this on a really local level. So most labor and delivery units track their C-section rates and track their postpartum hemorrhage rates. You can, possibly use the electronic medical record system to help you stratify those outcomes by race or ethnicity or language. So that can be really helpful. And I also think that data, if you have it, it really should be presented to the people who are taking care of the patients on the ground. It holds the team accountable, it creates awareness. And again, if you track these outcomes, it's something that you can follow over time and show your improvements over time. This can also be done on a more regional level. So it's already been mentioned that Kansas and Missouri both have a state maternal mortality review committee, and they do look at race in those committees. And then I do want to point out that if you are using race and ethnicity, that it should be self-reported. Okay, evidence-based solution number 3. So it's really important to listen to what patients and the community have to say about your institution or your practice and what they perceive to be problems. Patient survey data can be really helpful to review that. You can invite community members into your health equity committees if you have one. And I want to mention too that one way to get the community involved is to work with community-based doulas. They're really uniquely positioned with one foot in the social community and one foot in the medical community. So they can really advocate for their patients in a way that people within the health system cannot. So community doulas can be really helpful. And I'm going to focus a little bit more on doulas here. So this is another slide from the CMQCC, or the California Maternal Quality Care Collaborative. And it highlights just all of the benefits that doulas have been shown to have. And as you can see, they're numerous. So studies have found that their patients are less likely to have a C-section if they have a doula with them. Their pain control is better, and their neonatal outcomes are actually better as well. So at KU, we were honored to receive a grant from BioNexus a couple of years ago that allowed us to conduct a randomized controlled trial. So we looked at patients who were coming to our clinics for prenatal care, and we randomized them to doula enhanced care or standard care. Everyone is enrolled, we're done enrolling, and we're in the process of having those patients matriculate through the study. So we're collecting outcome data and survey data. So I can't share any results, but I can share some things that I learned about incorporating community doulas into a larger institution, a larger health system. So number one, if you're going to build a program like that, I think it's really important to involve the doulas from the ground up. So we kind of did it in reverse. We thought of our study design and got the funding and got the IRB approval through KU. And then we found our doulas. And of course, they had some really great ideas of how we should conduct our study that would have been helpful several months prior. So involve the doulas from the very beginning. I also think it'd be really helpful to orient doulas to a few specific things to your labor and delivery unit. For example, it'd be nice if they knew your NPO, your eating guidelines for patients who are in labor. It'd be nice for them to know what you typically recommend for induction, or whether or not you recommend early rupture of the membranes. They can help their patients kind of make those decisions before they're actually admitted and in labor. And then, as healthcare providers, as nurses and physicians, we're really used to being our patient's advocate on our own. But I think it would be really helpful if you're going to have more community doulas to really train the healthcare providers how to have more of a team-based approach to make sure that they are being incorporated into your care. Okay, evidence-based solution number 4, implementing best practices. So there's a number of resources available to help organizations implement best practices. And the goal here is to minimize variation that's going to introduce bias into your care. I have a few resources down here on this slide. So the Alliance for Innovation on Maternal Health is AIM. I've already mentioned a few times in this talk the California Maternal Quality Care Collaborative. That's a really great resource. It's free. You can register for free. They have webinars and toolkits and all sorts of things that can help you minimize variation in your practice. Society for Maternal Fetal Medicine and ACOG, or the American College of Obstetrics and Gynecology, if you're a member of either of those. They also have lots of safety bundles and checklists that you can do to minimize variation in care. And then the 5th and final evidence-based solution I want to leave you with today is the role that leadership has on empowering and really motivating health professionals to improve the quality and equity of care they provide. So leadership really can ingrain, equity as a strategic goal and establish a culture of community on the unit. Institutions should really invest their resources towards this health equity goal. At KU, we actually hired a director of birth equity, Dr. Charlotte Smith. She's been really instrumental in helping us identify our gaps and implement change in education. And then circling back to solution number 2, some of those resources really should be used to help collect data, whether it's paying for extra data analysts or paying for extra tools that your EMR can then use to create quality dashboards where these things can be stratified by race. I already mentioned that these efforts should be multidisciplinary if they're really going to work. So make sure you include your OB anesthesiologists and your pediatricians and your neonatologists and your nursing colleagues. And then healthcare institutions can create equity committees. So our health equity committee is in charge of the implicit bias training. It's an annual training that we do every year. It is a half day. They're also in charge of looking at all of our data and trying to figure out what's meaningful, how to distribute that data to the people taking care of patients. And then leadership should communicate their efforts really widely. So I will let you read this slide on your own, but one of the first things that Dr. Smith helped us create was a birth equity statement. It's provided to each patient when they're admitted. It's hung on our labor and delivery unit. And it's really a reminder both for patients and patient families, but also to faculty and staff of what our priority and intent is. So in summary, inequities in maternal morbidity and mortality exist among different races. Systemic and structural racism has led to these inequities, implicit bias, and obstetric racism that contributes to these disparate outcomes. And hopefully you can employ some evidence-based solutions like addressing implicit bias in the medical setting, using data to enhance surveillance and identify gaps, collaborating with and listening to patients and members of the community, especially consider some community doulas, implement some best practices to minimize variation in your care, and then communicate maternal equity as a priority through leadership. That's it.
Can I just ask a question real quick?
Sure.
So that was fabulous. What a great presentation. I'm really impressed with the efforts you're taking. Have you been able to sort of track your care and outcomes by race? And have you seen with a lot of these iterative steps a decrease in any observed differences that may have existed beforehand?
Yeah, that's a good question. So we started stratifying our outcomes by race about 2 years ago. And because of sample size, it's hard to really determine if there's any difference. Right now, it looks like a lot of our perinatal outcomes are very similar between races. I'm sure that that's not true. I'm sure that over time, with bigger numbers, we'll be able to see a difference. But we have started tracking all of our outcomes by race. The first step was just leveraging the electronic medical record to collect outcomes at all. So we now have a quality dashboard that took a couple of years to create, and it's just pulling data from the electronic medical record and then showing it to all of us. And now we can drill down to race specific.
I don't know if the other presentations will get to it or not. How behind for maternal mortality, that you showed, I think, on the first slide, came up before.
Mhm.
Are those women getting care? And how much of that is out of hospital or out of clinic births, et cetera, et cetera? That kind of thing?
Yeah, that's a great question. Yes, a lot of these patients are getting care.
They are doing.
A lot of them are. I don't have a statistic on the top of my head. I don't know if someone else in the audience might. But a lot of them are getting care. It's not an issue of, no prenatal care. I think there's lots of different things contributing to this. Our patients do have more morbidities now than they did 60 years ago. But there's also lots of other things going on.
The high rate of maternal hemorrhage, it's surprising. It's too long.
Yes, there's lots of surprising things.
Just a random question that popped into my head as you were going through this. Do you feel, and it's not something I've thought of before, so maybe there's maybe there's not. But I'm just curious, I know there's been a backlash around the DEI movement, at least in the past year.
Mhm.
I wonder, would there be any reason to believe that with that backlash, we're going to see worse outcomes now than we've ever seen?
I hope not. I think this has been such an important goal for so many larger institutions that, we have found ways to work around the rules. So we don't call it DEI work anymore. It's health equity work. And so you do the work a little bit differently, but you're still doing the work. I think it's taken us a long time to, realize how important it is and what our role in it really is. And now that we're focused on it, I don't think most, institutions are going to let it slide.
I guess I want one more random question. I think a lot about like equality in general and the way that women are treated in our society and viewed in our society in the countries that you have on the prior slide that was the opening. Take a picture of it, and the countries that have the best maternal outcomes tend to have a lot more gender equality than America does. I know we're not the worst by any means, but does that play a role at all in the maternal deaths that we see? Like, are women just in general not listened to, and it's even worse for women? I don't know.
Yeah, probably.
I'm very suspicious that, a lot of it is, critical dysfunction of US healthcare payments, right? I mean, most of those countries have national coverage, and in Missouri until January of this year, half of the deliveries were on Medicaid, and Medicaid coverage in 6 weeks after delivery.
Yeah.
And, so if you have and a lot of these maternal deaths are occurring between delivery and 1 year. So those
They can hear you.
I'm too embarrassed about
Yeah,
what I'm saying.
they're saying they can't hear you.
But I think that there's just, those are a lot of the challenges that separate the countries. We're working very hard to try to figure it out. So we're meeting, I think you guys are participating in the Hope Registry, but we have a study, the Notice of War just came today. It turns out that for 2 to 3% of all pregnancies are complicated by cardiovascular disease, and it accounts for over a third of the deaths. And it's an evidence-free zone. I mean, no disrespect to your profession, but they just don't have the data in cardiology that we have to risk stratify who in what risk category should we be thinking about, inducing earlier than later. How should we be what structures of care, are associated with better care and outcomes. So there's so much sort of medical side, but what I liked about what you really focused on was the patient side, and the doulas, trying to figure out how to address systemic racism. I just became a grandfather a week ago. It was incredibly difficult for my daughter to find a place, and I ultimately couldn't find one to have a natural birth. And nurse midwives almost don't exist in Kansas City, and so there's some real sort of structural challenges even beyond some of the
Yeah, you're right. And part of it too is, like in the rural setting, what you were saying, the maternal level of care is a big deal. There's very few centers that have expertise to handle cardiac conditions. It's, we have patients that drive hours to see us and then they go home and they have a cardiac condition and they're pregnant and we hope they're fine until their next appointment. And so maternal level of care and when to transfer is a really big deal. So that's part of it. Definitely Medicaid coverage. Postpartum is huge. Kansas, I think I should definitely know this, but I think we just extended our Medicaid coverage like this summer. But it was a long road to get that covered. And then also maternal mental health. We are just scratching the surface of maternal mental health. And there have been a few studies that have found, gosh, I wish I could remember the statistic off the top of my head. I think it was at least 25 or 30% of these maternal mortalities were linked to some type of maternal mental health disorder that we, again, just have not addressed fully. So, I am really hopeful that now that we realize this is a big problem and we are part of the problem, that we'll continue to work to find solutions.
I think there are two really good things in your favor. One is that there's a huge amount of work to do to improve and make a difference. And two, you're very young, so you have a lot of time to do it. So congratulations. That was a really great presentation.
Thank you.
I would invite you to the work of Kimberly Crenshaw, who wrote about intersectionality, which is the idea that Black women experience multiple forms of oppression at the same time, and being at that nexus of multiple forms of oppression likely does have a greater physiological, psychological impact.
And you could look up the term weathering.
Thank you. Right.
Dr. Martin, thank
Okay.
you.
Yes, you're welcome.
We've had a request that when the audience asks a question, that the question be repeated so that folks online can hear. And I also turned the volume up on that. So maybe it'll sound a little better when Ashley Otto speaks.
All right, so I don't really need to do anything other than introduce Ashley Otto. Thank you, that was an amazing presentation. And also, I only wanted to interject one other thought on because there's a million thoughts, right? Like we know that we're bad for a multitude of reasons, and if we keep denting or chip away at all the problems. But one other one that I think is interesting about other OECD countries compared to ours is how they pay for services that are not just medical too. So it's kind of that does also hit some of these issues, so social services and wraparound supports and things of that nature are often that's how they view medical care, and we don't here. And things are changing. I shouldn't say everything is black and white, but I think that also is another contributor that also impacts mortality. But that being said, this has been already a great discussion, but I will turn the floor over to Ashley to present to us.
Thank you. Just making sure, do you want a quick mic check again?
We hear you. We hear you. We hear you very well. So we're going to work on our volume.
Okay.
There we go. Thank you. We're good.
And
Right.
are you hearing us better from the room?
As long as you all speak in the microphone, I can hear well. I'm not sure about the others on the call.
So we'll arrange for the question to be repeated. Okay. Thank you. The floor is yours.
All right, thank you. So my name is Ashley Otto, and I work at the Missouri Department of Health and Senior Services in Jeff City in our Office on Women's Health. And today I'm going to talk to you about outcomes of Missouri's Pregnancy-Associated Mortality Review. So this is just a little glimpse from our report that was just released about a month ago, and it covers data from 2017 to 2021. And I just want to level set that and acknowledge that different communities, professions, and partners all have a role to play in improving maternal health in Missouri, and especially our bordering states. We work really closely with our partners in Kansas and Illinois with their maternal mortality committees as well. So this slide here just gives us a glimpse of a few of the key findings from our 5-year report. So on average, we see about 70 women die in Missouri each year during pregnancy. This equates to almost 350 women in that 5-year period. We have 4 leading causes of maternal mortality, and they alternate between years, but when we combine the data into 5 years, Our leading cause was due to cardiovascular disease, followed closely by mental health, and then infection and homicide. And I'll go into more in depth in those in just a minute. I also want to note that the pregnancy-related mortality ratio, was 2.5 times higher for Black moms than white moms in Missouri. The ratio of deaths for women who were covered by Missouri Health Net or Mo Health Net, which is Missouri Medicaid, was more than 7 times greater than those with private insurance. I also want to highlight that deaths were determined to be preventable in about 4 in 5 pregnancy-related deaths, so almost 80%. I do want to also touch base on the disparities that we see between Black moms and white moms. We are seeing the disparity gap narrowing. That is in part partially due to the increase in deaths to white moms, but we have also seen a decrease in the number of deaths to Black moms over the last 5 years. So we truly are seeing that disparity narrowing. So going a little bit more in depth on our pregnancy-related deaths, I just want to level set and make sure everyone understands the terminology. So when we talk about pregnancy-related deaths, this is a death due to, this is a death during pregnancy or within 1 year of pregnancy that is as a direct result of the pregnancy itself, or it can be from a complication during the pregnancy or delivery or postpartum. It can be a chain of events initiated by the pregnancy, or it can be an unrelated condition. So let's say they had a comorbid condition that the actual pregnancy itself exacerbated. So what we were able to provide in this 5-year report was a regional breakdown of our pregnancy-related mortality ratios. And so we ended up breaking this down into what we term our BRFIS regions, which is the Behavioral Risk Factor Surveillance System. This is a nationwide surveillance system that utilizes a phone survey to ask individuals about various factors with their health, with their access to care, and so forth. So we felt breaking it down into these regions would allow individuals across the state to compare with our maternal mortality ratio to other BRFIS indicators. And so if you'll kind of note, one thing that was a little surprising for those of us in Missouri was that the Northeast region actually at this point had the highest rate compared to what we historically have seen be the worst outcomes in the South region or the boot hill of the state, but also of indication, the Kansas City metro area being at 31 per 100,000 live births as well. So this kind of gives you a glimpse at the regional level what's going on. Also, you'll note throughout our report and the data that we present that we do our best to share as much data that we can, but that we have an obligation by law, but also to make sure that we don't identify any individuals. So you will see this throughout the report being an asterisk. You will also note that there are areas that we gave you more of an indication that, maybe perhaps the count is less than 5. So I just wanted to note that as well. This slide here shows the pregnancy-related mortality ratio per 100,000 live births by race and ethnicity. So when you look over to the right in the 5-year aggregate here, you can see that large disparity between white and Black individuals. And then, as you will also notice throughout the report, there are areas like on the bar graphs where perhaps the bars are hashed. And what that indicates is an unreliable ratio. So typically, when we have counts less than 25, adding or taking away even one can really alter the rate. So we indicated those being as unreliable with the hashed bars. Again, kind of looking at those leading causes of pregnancy-related death in the 5-year time frame, you can see again cardiovascular disease being our leading one. We also broke this down by the leading causes within that group. So when we're looking at cardiovascular disease overall, you can see the majority of those were due to cardiomyopathies, and then those remainders were other cardiovascular conditions. When we're looking at mental health conditions, you can see the overwhelming majority of those were due to depressive and anxiety disorders, whereas the remaining 15 were due to substance use disorders. Again, one thing that was slightly unique in this year's data is that infection actually led as a third leading cause of death, and that was largely due in part to COVID-19 deaths being added with our 2021 data. And I apologize if my slides are no longer showing. It's showing I have an unstable network connection, but I will continue to talk due to time. And so then again, looking at the fourth leading cause of death, this has been alarmingly one of our leading causes for the last 5 years, and that being injury. And at this point in time, 100% of those has always been due to homicides to pregnant individuals. Okay, I think I might need to share again.
I can do that for you if you like.
Here we go.
Would you like me to share for you?
Yeah, sure, that would be great.
Let's see how we do. And if you want to tell me what slide to go to.
Sure, and sorry about this. Sometimes I have an unstable network connection. Okay.
Keep going.
Yes, please keep going. We will be on slide number 8.
The numbers aren't showing on my computer, but.
Okay, back up just a couple. One more before that, I believe. Yep. So yeah, you can get more information in the report though about the leading causes of death, and also within this year's report, what we did slightly differently was we added the recommendations from our PAMR board underneath each of the leading causes of death. Next slide, please. This slide here, just again, where we were able to provide as much granularity to the data as possible, we did so. So this shows the leading causes of death by race and ethnicity. And again, as previously mentioned, we're not seeing a large difference in cause of death by race and ethnicity. But those are data points that we're continuing to look at. And it may just be due in large part to small numbers as was mentioned again below or before. Next slide, please. So our board also determined if discrimination played a role in or was a factor that contributed to the death. And as you can see, about 1 in 9 or 11% of pregnancy-related deaths, the board determined that discrimination did play a role. And when we look at discrimination, the board looks at all sorts of things. They look at you know, the different determinations such as social economics, stigmatizing language, age, race, class, and other variables. It's not just based upon the color of the individual skin. Next slide, please. So other key findings I just wanted to highlight quickly is about a little over half of the deaths due to cardiovascular disease, they started prenatal care in the first trimester. So what we like to think about on this one is that almost half of moms who died from cardiovascular disease did not initiate care in the first trimester. So what can we do to help improve prenatal care, seeking prenatal care in the first trimester, getting individuals with insurance to get them in as early as possible and so forth. Also, just to note that 91% of overdose deaths involved polysubstance use, with toxicology identifying opioids as the most common class of drugs, followed by stimulants. So again, what we ask here and what we think about is that individuals are either intentionally using polypharmacy or unintentionally. So did they know that what they were buying was laced with fentanyl? How can we, throughout Missouri, inform our communities of, you know, the polysubstance in their drugs that they may be using? Can we provide fentanyl test strips for them and so forth? Also to note as well that the majority of deaths due to infection, again, were from COVID-19, and that most of the individuals were unvaccinated. So how can we make sure that we're relaying that information accurately to individuals to make sure that we get vaccinations that are recommended during and after pregnancy? And then again, in each case of injury or, you know, as I mentioned previously, of homicide, the perpetrator was a current or former partner, and most had a documented history of intimate partner violence. So we are working really closely with the Missouri Coalition Against Domestic and Sexual Violence to develop a provider training on, you know, common tactics used during and after pregnancy, and, you know, ways to make sure we are connecting survivors to support services and advocacy services for intimate partner violence. Next slide, please. Okay, and now I just want to briefly highlight the pregnancy-associated but not related deaths. So those are deaths that we determined that occurred within that 1 year of pregnancy, but that the board did not think that the death was directly related to the pregnancy itself. So we can learn a lot about, from these deaths, including like common stressors, areas for health improvement overall, from, you know, not only the pregnancy related, but also pregnancy associated but not related deaths. Next slide. The leading means of death for pregnancy-associated but not related deaths were overdoses, followed by motor vehicle crashes and firearms. And so I just want to highlight that the majority, or about 1 in 3 motor vehicle crashes occurred during pregnancy. So if you look at the timing of death for other causes, no other cause has as many deaths during pregnancy as motor vehicle crashes do. And about 1 in 2 were unrestrained. So a big push for education on seatbelt usage during pregnancy and in the postpartum period, of course. Next slide, please. When we're looking at pregnancy-associated, not related deaths and the disparities, what we are really reviewing here is we're comparing a range of population characteristics, both modifiable and unmodifiable. And what this does is it helps us see what differences that we notice and when we looked at the Panner deaths, we analyzed the characteristics that are not modifiable, such as race, and those that possibly could change, such as residence and weight. So again, these are strictly indicators. They're not the cause of death. So we cannot say that someone died because they were not married or because they were Black. Instead, what these indicators could potentially point towards are causes and solutions. So we begin to ask ourselves, what resources do married women have access to that women who are not married do not have access to? What resources do women who live in urban or metropolitan areas have that women living in rural areas do not have, and so forth. And so what we could glean from this is that how do we get access to care in parts of our state that don't have access? Can we use telehealth? Do we provide transportation? Are there other solutions that we can look at and get our community partners together for that? Next slide. So I just want to briefly touch base on really a call to action. In next slide. I just want to also note that when we're looking at recommendations, the recommendations can really fall within one of 5 levels. So we not only look at what we can do as providers, we look at what the facility can do, what the community can do, what the system can do, what the patient and family can do, and what we all can do to work together to end our maternal mortality. Next slide. So briefly, I just want to touch base on some of the key recommendations. So all providers should utilize screening, brief intervention, referral, and treatment throughout the prenatal and postpartum period. So there are guidelines that ACOG recommends screening at the initial prenatal visit, later in pregnancy, and then also at the postpartum visit, utilizing standardized and validated instruments. And that also, it's important to note that those who may need more frequent monitoring are those who have a history of depression or other co-occurring mental health conditions, those that have taken psychiatric medications in the past, or have screened positive for perinatal mood and anxiety disorders in previous pregnancies. And so those individuals, obviously would need more support and more touch points with our healthcare system and support systems. Next slide. Facilities that we utilize social workers, community health workers, and doulas during pregnancy and postpartum to increase continuity of care, care coordination, communication, and to also help address the social determinants of health. And that facilities should establish protocols in alignment with ACOG guidelines for pregnant women who come in for treatment with COVID-19. Next slide, please. That there are things that we can do as a community is working with our community partners alongside our providers to reduce stigma surrounding maternal mental health and SUD and provide assistance with these resources. We should also collaborate together and provide education on intimate partner violence and what resources are in our local communities to help those affected by IPV. Next slide. This is a little bit from our what we would consider system level recommendations. So government agencies in partnership should invest in urban infrastructure. These would help really foster healthy communities and really reduce the violence that we are seeing and improving maternal health in our communities. And of course, all insurance companies should ensure pay parity for psychiatric services. Next slide. A few more about the system. Continuing is that the Department of Social Services should really evaluate their Medicaid enrollment process and make sure that they're in alignment to facilitate early entry into prenatal care, and that the state should work to enhance the workforce for psychiatric services. And then lastly, just to wrap things up, is the state, in partnership with our community partners, should implement harm reduction strategies for the perinatal population. Next slide. So I just want to end that maternal mortality in the state of Missouri and in our nation is exceptionally complex. There are social inequalities, lack of access, health disparities, and then the ongoing opioid epidemic, and that, again, we all have a role to play to help prevent maternal mortality. In the next slide is just questions. So feel free to ask them now, or if you want to hold questions till the end, I'm available. There's my contact information as well, and our website that you can actually get a full report if you want to read that full report. Thank you so much.
Karen and Tracy drop out.
Thank you so very much. That was absolutely terrific. And I think that we now have some questions in the chat. I wanted to say that, you know, we had two other presenters here that were going to be here today. And, you know, sometimes life just really interferes. Karen Florio, who's been a real champion for our efforts here in Kansas City, one of her colleagues was hit while jogging and is now in the ICU. And so she got pulled to cover for him and so wasn't available. And Tracy also had a medical emergency, even though she showed up at the beginning. We didn't get a chance quite to hear their perspectives. But the two presentations we did have were just fantastic. And I'd like to open up for questions from those here in the room. And then I'll also, with my terrible eyesight, look at some of the questions that were posed online, or people who pose questions online. If you want to come off mute and raise those, I would love to entertain them here.
There's a question from John Fitzpatrick. Statistics are.
Yes. I'm sorry. I think maybe that might be for me, so I'm happy to answer that. Yes, I definitely understand that, you know, when folks see this data, they're like, you know, why is it so far behind? Currently, right now, our state board is reviewing 2022 maternal deaths. Part of the reasoning for that gap in, you know, being real time is that just due to the nature of the process. So, you know, the death has to be registered in our state, and then we actually query those deaths on a quarterly basis. So we're already receiving deaths from the summer of this year. So we know about them, we're gathering information about them, but once we begin a new year, our abstractor then has to take each individual case, request records, sift through all of those records, and then enter a lot of information into a system that then helps us analyze this data and be able to put these types of reports out. And then, you know, before we get to that analyzing piece of things, we have to then present these de-identified cases to our board for review. And our board currently meets every other month for a whole entire day to review all of these cases. So it does take some time to go through. We got a bit behind last year. Nationally, but, you know, also in Missouri, we've seen a really large increase in deaths in 2020. There was approximately 20 to 25 and even more at times once we were able to, you know, go through the whole process. But we had about 30 cases more than we do on any other given year in 2020. So it took us a lot longer last year and got us behind the ball just a bit, but we've done things to be able to get more real time. I know that's a long-winded answer, but I hope that that helps a little bit to, I guess, show that, well, we're seeing 2021 data, but we're in 2024. I will note, though, I've been doing this program since 2015, and I consistently see the same ongoing things from year to year. So even though the statistics may change some, I'm still seeing the same things that are occurring that occurred back in 2015 right now.
And if you
An example, oh, go ahead, sorry.
as you say, it's got to be frustrating seeing the same thing year after year after year. You put some recommendations out there, but if you were king, what would you try and implement next year to try and make the biggest impact on mortality, or if it's even a broader issue, morbidity, because obviously, and I think you raised this, for every death, there's a gazillion adverse pregnancy outcomes, adverse neonatal outcomes, other major adverse maternal outcomes that don't result in death, but can, markedly increase people's risks for adverse health over time. And, what would you see as the lowest hanging fruit to make the biggest impact, Ashley?
I think there's a lot of things that, fortunately, our state has prioritized maternal health, and there are a lot of initiatives that are, ongoing right now. So my hope is that the things that are occurring, such as Missouri's Perinatal Quality Collaborative, I'm sure you're familiar working with a lot of the hospitals across the state. There are a few that are still straggling to, come into the Missouri PQC. So we're still encouraging at every avenue to get every hospital involved. But a lot of that, again, looking at your data in your facilities, in your region, looking at the statewide data can really help inform a lot of the low-hanging fruits. So I hope that is somewhat helpful. I would just encourage folks.
I'm curious, the Center for Medicare and Medicaid Innovations put forward an opportunity for transforming maternal health. Do you know if Missouri applied for that? Because that looked like it would bring together an awful lot of resources and expertise and attention for addressing this very problem. Did we apply?
I am not certain if we did or not. I would be able to connect with our partners at Department of Social Services. I know we've worked fairly closely with them over the last couple years on maternal health, but I am not 100% certain if they ended up applying to that. I hope they did.
Yeah, it would be great to work with them. Other questions, Kat?
Yeah.
I see there's one about harm reduction in the perinatal population. Some of the things that our office is going to be working on is putting together what we are terming essentially a perinatal harm reduction kit. So we've worked with our folks that are in the world of opioids and overdose prevention, and really looking at, so when we see these deaths in our perinatal population in our case reviews, there are several things that really stand out to us. One being the SBIRT process not really fully being implemented at each interaction. The second thing is individuals with a history of or a current usage of substances. There are not a lot of giving of naloxone for that prevention purpose. Not a lot of education on that if they have access to it. So we are essentially going to be working on putting a kit together that has, fentanyl test strips, that has naloxone, that has education materials in there for individuals that We primarily want to target our OB offices and clinics and have them have these kits available so that when they have an individual that they see for care, they can grab a kit, give that kit to them, and it would kind of, have everything in there needed for that harm reduction. There will be some other items in there as well for harm reduction, but I'm excited and I will share that information with you all whenever we get that completely put together.
Thanks, Ashley. Great presentation. Really appreciate all of the data that you're putting together and presenting that to us today. Question for both you and Dr. Martin, as you sit on the maternal mortality review committees in our respective states. Is there any other source of data that's being pulled in aside from the extractions from medical records? For example, are patient satisfaction surveys being examined, or police reports, or any other interactions with law enforcement, those types of data streams?
I don't sit on the Kansas.
Oh,
Yeah,
I'm sorry.
No.
Well, you should.
Dr. Martin just let me know she does not sit on that committee, so that's my bad, but happy to hear from you if you
That's
have any.
okay. I try. I don't know all the details of the Kansas, but typically we all work pretty similar. So we get as many records that you can possibly think up. Our abstractor looks on social media for, that type of information, because you get a lot of firsthand information of what's going on outside of the, medical touch points. We get law enforcement records, unless the case is open, then those are not available. But for the most part, we can get law enforcement records. We also work with our violent death reporting system, VDRS and SUDORS. It's the Substance Use Disorder Opioid Response System. And we are working to share our reports from medical examiner offices so that, we're 3 different programs in the same department, all requesting similar, if not the same, records on our cases. Our abstractor also looks on CaseNet for both the decedents, and then in instances where, intimate partner violence, or maybe it was a homicide, she tries to look up information on the perpetrator or the suspect. So that's, we really try to be as comprehensive as possible. In our report, a lot of times we do, or we at least did include information from our pregnancy mortality surveillance system. One other way that we identify, this is more medical interactions, but our data analyst utilizes our patient abstract system, which is essentially anytime an individual seeks care in the emergency room or as an outpatient, there is data that's entered into the system. And so he runs that with that system to help us identify interactions with medical facilities and so forth.
John, I'm not sure I saw it right. Was there a slide that showed lack of prenatal care as a 345?
Yes,
is the number of deaths, but I can't remember what you had.
I think it was a non-pregnancy, not birth-related mortality events, and what that slide didn't have was the comparison rate of the people who weren't Black, for example, but lack of prenatal care, clearly was the leading cause. Correct me if I'm wrong, Ashley. Of people who died, but it wasn't felt to be due to the pregnancy itself, but it's probably a marker of, significant barriers to healthcare access. Is that the correct way of interpreting that?
Absolutely. You couldn't have said it. I couldn't have said it any better. So yes, when we looked at our pregnancy related deaths, there was not a statistical significance looking at prenatal care utilization. In fact, the majority of individuals had adequate prenatal care, but that was different, again, as you noted, with our pregnancy associated but not related deaths, that huge disparity with no prenatal care. And again, if you think back to the policies in Missouri during this time period, Medicaid was not extended, nor did we have postpartum Medicaid extension as well. So my hope is that we will begin to see this, a difference in this, and hopefully a positive way due to the Medicaid extension and then expansion for postpartum moms. But I do think we still have a long way to go.
Well, so I really want to thank the presenters today. I apologize a little bit about some of the other perspectives not being shared, but you guys actually completely filled the time, which was great, and raised a lot of important issues for consideration, both sort of laying out the scope of the problem and the challenges that Ashley did, but also thinking about how a system could really reflect internally and think about the strategies under its locus of control to create and support more equitable care. This is obviously a huge commitment for the country, for the region. At High IQ, as was alluded to earlier, we're really trying to create a strategy to improve the success and equity of maternal care in Kansas City, and have been working with a group that has settled on trying to really address hypertensive disorders of pregnancy as the initial focus, with three sort of arms to that. One being initial screening and hopefully prevention for preeclampsia early in pregnancy. The second is really rapidly addressing hypertension when it occurs and discovered. And the third is thinking about the transitions of care to follow up longitudinal primary care for people who have hypertension disorders of pregnancy, given it's a substantial cardiovascular risk factor. And sometimes the blood pressure goes right back to normal after delivery, other times it doesn't, and people need to be screened and monitored over time for that. These are all sort of interventions in evolution. We're still thinking about the right partners to collaborate with, primary care offices, community-based organizations, the health systems and hospitals themselves, and really would like to encourage those who are interested in contributing and working on this, because our vision is that, coming to a lecture, talking about it, certainly can create anxiety and raise problems, but doing something about it and really making a difference in the health of our community is really what motivates so many of us. And so we're very committed to sort of bootstrapping this initiative in the larger Kansas City region on both sides of the state line. So Kat, who asked the question earlier, is going to be sort of the project lead for that within High IQ. But we have a number of people who've really been incredibly helpful in getting us to where we are. We have a lot of work to do over the next few months. About next summer is when we hope to be launching it, but it may take longer than that because we have a lot to do between now and then. If there are not any other questions, I would flag on November 21st that we're having the next and last forum of the year on rural health issues. And so this is obviously a very big challenge in access to care. It affects, as you alluded to, complex pregnancies. It affects a myriad of conditions, and there are also tremendous disparities with much worse outcomes in people living in rural communities, and there's a shrinking of access to hospitals and other safety net hospitals and care facilities there. So any final questions, words, or? I do hope you'll come up and reach out to us if you're interested in those online, that you'll reach out perhaps through Pat if you would like to help us collaboratively figure out how to do better in our region. And thank you all so very much for coming.